Welcome to the short video presentation on the recognition and management of maternal sepsis, and we'll be doing this practical session in our SWIFT-M multidisciplinary, multi-professional training just to improve our skills on maternal sepsis management. So let's look at what happens when bacteria invade our systems, organs, tissues. So we need to have a sufficient bacterial load, and the bacteria should be virulent if they have to cause serious infection. So the virulence and the load of the bacteria are key determinants on how unwell we would become. On the other hand, the host, that is us, we will also mount an effective host response to save ourselves by killing off the bacteria. So during pregnancy and childbirth, the bacterial load is often due to an ascending infection. That's the commonest route by which the bacteria invades the fetal compartment and then ends up invading the maternal compartment. And then you have predisposing factors. For example, if I do membrane sweeping, I'm introducing a load of bacteria, and if it is from the lower part of the vagina where E. coli and GBS naturally habit, we are going to introduce those virulent organisms into the uterine cavity. So membrane sweep must be stopped because there's no evidence that it is effective. Cochrane systematic reviews have said the effectiveness is about 20% based on very low to moderate quality evidence. And in countries where prostaglandins are not available, they have no choice. But if you have prostaglandins which can be placed in the posterior fornix of the vagina without going through the cervical canal, then membrane sweep in that kind of settings is not recommended. Or we have poor aseptic technique. During cesarean section, if you have intrauterine infection, it can easily spill into the peritoneal cavity once the uterus is opened. So the virulence that we learned in microbiology in medical school, that the three determinants of how bad the infection is our bacterial load and the virulence of the organism, as well as how well we are able to fight the organism. So when we published this opinion paper in 2021, it was based on both scientific evidence and common sense, where we said this is no longer an acceptable practice in contemporary obstetric practice in countries where vaginal prostaglandins are available to induce labor. Unfortunately, some obstetricians still continue to do a membrane sweep. It's called Hamilton's technique in some countries, where they put the finger in, try to separate the membranes with the hope that they are releasing prostaglandins when the effectiveness is only less than 20%, whereas prostaglandin pessaries or tablets will give you 80 to 85% success rate without introducing a bacteria inside the amniotic cavity. And in 2024, the European Parliament has now listed Hamilton's technique as an example of obstetric violence. And therefore, we can be charged under the human rights law if a woman complains, because these are all historical practices which have no place in modern obstetric practice in countries where prostaglandins are available, because it's not only uncomfortable for the patient, it doesn't have sufficient benefit compared to what is the alternative that is available, that those are prostaglandin pessaries, which release large amount of prostaglandins with high success rate compared to stripping the membranes and releasing tiny bit of prostaglandins with low efficacy. So when we looked at histopathological confirmed cases of chorioamnionitis, we were able to show that 95.4% of these fetuses had emergency cesarean section, and they had to go to the neonatal unit, and some of them stayed about 75% more than 7 days, and 80% of women came with wound infection. And when we looked at what happened 24 to 48 hours before the histopathology was done, before the birth was accomplished, it is shocking, but it's not surprising that 24 to 48 hours these women had membrane sweep. You can see the percentages. 84% of those who had membrane sweep had histopathologically confirmed cases of chorioamnionitis. And if you have a membrane sweep 24 to 48 hours later, there's more chance of having cesarean section and getting admitted to the neonatal unit, and also the woman coming with wound infection and readmissions. So it is not rocket science to say that if you push vaginal bacteria into the uterine cavity with 2 fingers or 1 finger, whatever it is, to do membrane sweep, we are just increasing the bacterial load and causing problems for both mothers and babies, increasing the risk of sepsis. Because once the fetus gets severely infected, the bacteria will go through the umbilical arteries, through the placenta into the maternal system. Or when the placenta gets delivered, there's a large bolus of bacteria that can enter from the amniotic cavity directly into the mother's venous system, making the mother unwell. So let's stop those historical practices. If you think about cytokines, we use interleukins, interferons, and other cytokines to fight the bacterial infection, but the problem is they are non-specific. Because they are non-specific, they are going to attack our normal tissues and organs. And that is why we have systemic inflammatory response syndrome, which involves multiple organs, including myocarditis, ARDS. This is what maternal sepsis does to women. So initially the bacteria comes in, we try to fight the bacteria, we have a very strong immune response, we produce pro-inflammatory cytokines like interleukin 6, interleukin 1, tumor necrosis factor alpha, and they end up not only destroying the bacteria, but they go and destroy wherever there are proteins. Those are our vital organs. And we may have neuroinflammation as well, and leading to endothelial damage and pulmonary edema, cerebral edema, disseminated intravascular coagulation through the damage of the endothelium, and increase maternal core body temperature, increasing oxygen demand and oxygen requirements, predisposing to lactic acidosis due to the onset of anaerobic metabolism. And because the bacterial toxins and cytokines, they attack the blood vessels and cause vasodilatation due to vasoparalysis, the patients will not be able to maintain the blood pressure and they become hypotensive. And that becomes a vicious cycle, because if you are hypotensive, you are not able to perfuse your organs and you get multi-organ failure due to reduced tissue perfusion. So pregnancy has a special risk factors because of altered immune response, and we do lots of interventions apart from membrane sweep, including artificial rupture of membranes, repeated vaginal examinations, and in some countries, unfortunately, despite evidence concluding that it is not useful, they use a technique called fetal scalp blood sampling, where they are using invasive instruments entering into the amniotic cavity. If you introduce infection into the amniotic cavity, because of altered immune response, we can easily get infection. And also because the back passage, the anus, is very close to the birth passage, E. coli, GBS, and other gram-negative organisms which normally inhabit the bowel can enter the vagina and cause contamination. So all these, it's the chorioamnionitis is not only the problem to the fetuses where they have high rates of morbidity, mortality, and neonatal admissions. It is also a problem to the mother, and this is why we should not allow uterine contractions to continue, because that will reduce blood supply to the fetus with increased metabolic demand. So, as I said earlier, let's not forget that membrane sweeping can give rise to problems. So, we are going to look at sepsis as an acute obstetric emergency, which requires an immediate management. And the management includes maternal stabilization, specific treatment of bacterial infection, and then management of underlying source of bacterial infection. Because we are going to have multi-system failure, we need to consider the wider clinical picture. If you have meconium staining of amniotic fluid, our study on chorioamnionitis showed there's a 38% association with chorioamnionitis. And therefore, if you are doing an operation with the knowledge of meconium staining amniotic fluid, or there is clinical chorioamnionitis prior to cesarean section, or the CTG shows 10% increase in the heart rate with zigzag or sinusoidal pattern, absence of cycling, we need to anticipate a sepsis, maternal sepsis, in addition to fetal sepsis. Because once you open the uterine cavity, once you cut the myometrium, we have no control. We would let the bacteria from the amniotic fluid to seep into the peritoneal cavity. We cannot prevent that during cesarean section. And as the bacteria enter the peritoneal cavity, which is very, very vascular, you are going to have rapid absorption of the bacteria and leading to bacteremia, septicemia, severe sepsis, and septic shock. And once we go into severe sepsis, septic shock, because of multi-organ involvement, we are risking multi-organ failure. So vital signs are very important. Commonly you get tachycardia, oxygen saturation would start to fail as the fall as the sepsis advances. There is air hunger because of increased metabolic rate and increased tissue oxygen demand. The rate and depth of respiration increases. Please don't forget to look at flaring of ala nasi or the use of accessory muscles of respiration. And towards as the sepsis progresses, due to the production of lactate as well as bacterial toxin and cytokine mediated vasodilatation, the woman is unable to maintain vasospasm, and therefore there is vasoparalysis, leading to reduced peripheral resistance and also reduction in the blood pressure. And if we think of all three factors that combine together, we know what to expect. So due to increased metabolic rate, you have pyrexia and tachycardia. Then because of vasodilatation due to toxins and cytokines and lactate in very end stages, we have warm peripheries, hypotension, and hypothermia. So initially the temperature goes up. That is followed by a reduction in the temperature because of hypothermia. Then as the endothelial cells get progressively damaged, you have a risk of disseminated intravascular coagulation, pulmonary edema, and ARDS. And multi-organ failure would include renal failure, and in end stages, it's myocarditis and terminal myocardial failure that results in cardiac arrest and death in sepsis. So this is the systemic inflammatory response syndrome. So if we find a woman with sepsis after cesarean section or after a procedure in the postnatal ward, the first thing is airway, breathing, circulation. We need to stabilize the mother or the patient by airway, securing the airway, ensuring the breathing is appropriate and adequate and the circulation is maintained. Then we look at the vital signs, check for multi-organ involvement, check for incisions, for any source of sepsis, and also investigations to exclude multi-organ failure. And severe sepsis requires a multidisciplinary input. We need the services of the anesthetist. We may need ICU, intensive care unit support. We may need hematologists if there is DIC. And depending on the source of infection, we may need other specialties, including microbiologists, to decide on the right antibiotic to give. So Sepsis 6 Care Bundle is very vital. It saves lives and it has to be immediate within the first hour. So there are 3 things that we have to give in, 3 things out. In is oxygen immediately, high flow oxygen, about 10 to 15 liters, because there's increased tissue metabolism and oxygen demand. If you don't give immediate oxygen, increased risk of anaerobic metabolism and lactate formation. The second in is your IV fluids to maintain blood volume because of vasodilatation in sepsis. Otherwise, you will have hypotension. The third one is the urinary catheter. The 3 out is very easy. The blood for normal investigations, including to check for multi-organ failure and blood cultures. Second, blood for lactate. And third out you're going to take is your urine output. So there has to be 3 in and 3 out to make sure that we have managed this patient properly to improve outcomes. We need to ask ourselves, do we have evidence-based, up-to-date, is not 10 years old, clinical practice guidelines in our hospitals? And we need to have this guideline with definitions. What do we understand by sepsis? That means infection. In addition, there's systemic manifestations of infection. It is a medical emergency. Severe sepsis, that is sepsis plus sepsis-induced multi-organ dysfunction and hyperperfusion. And then we have septic shock. That is severe sepsis, but that is persistence of hyperperfusion, which is not responding to fluid resuscitation, and the lactate levels are more than 2 millimils per liter. So we need to have the definitions right. We need to look at how to prevent these infections by us doing the right thing for patients and giving prophylactic antibiotics when necessary. And once there is evidence of infection and clinical chorioamnionitis in labor, then we need to give broad spectrum antibiotics to cover both gram-positive and gram-negative organisms plus the anaerobes. Because the upper part of the vagina is full of ureaplasma, mycoplasma, anaerobic organisms. So we need to cover not only gram-positive and gram-negative, and also anaerobes. And depending on the local antimicrogram in your own hospital, you should choose the right antibiotic for your hospital based on the resistance reports. So remember, when we wear gloves, when you do artificial separation of membranes, membrane sweep or Hamilton's technique, or when we do manual removal of the placenta, we are safe because we are wearing sterile gloves. But remember, when we take the hand into the uterine cavity, we are taking all the bacteria, both gram-negative, aerobic and anaerobic, with our gloves into the uterine cavity. And when we try to remove the placenta, our fingers, gloved fingers, are brushing against the maternal venous sinuses, and that's why antibiotic prophylaxis is extremely important in such cases, because you can have a bacterial storm and the woman can become very, very unwell. So the general clinical features are very easy. From medical school, we have initially the evidence of infection, where the woman will have fever, chills, rigors, etc. Then if you have community-acquired streptococcal infection, group A, and you might have generalized rash, etc. And if the source of infection is in the gastrointestinal system, diarrhea and vomiting may be one of the features. Then it all depends on where the bacteria is. You might have abdominal pain and tenderness if there's peritonitis. We may have offensive vaginal discharge if it is an intrauterine infection, and again urinary symptoms if it is UTI, and if there's pulmonary symptoms like productive cough. So depending on where the organisms are, clinical symptoms will vary. Please remember, temperature increases first in infection because of increased metabolic rate. But as the disease progresses due to vasoparalysis and release of body temperature, and we have hypothermia. So in early stages is hypothermia, increased temperature, then is hypothermia. And we need to look very carefully at the baseline heart rate. Please don't use set numbers for tachycardia. If my heart rate is 60 and if it goes to 80, I have tachycardia for me. I don't have to cross set population based numbers. And some of the medications such as beta blockers, or if the woman is taking labetalol for preeclampsia, that can also blunt the tachycardic responses. We need to carefully examine the patient and also make sure that oxygen saturation is monitored, and always the central venous pressure should be more than 8 millimeters of mercury, and we need to ensure that central venous saturation, oxygen saturation is maintained to ensure good tissue perfusion. And the Sepsis 6 is very important to remember: blood culture, serum lactate, and if it is more than 4 millimoles despite fluid resuscitation, that tells you very poor perfusion and is unresponsive. And then we have other blood tests. So thank you very much. Now we would discuss a case in our course and see how we can apply these principles in managing a case with maternal sepsis. So let's now look at a case.